Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections.
Today, we're looking at an invisible invader, one that probably lives right in your own backyard.
Yeah, a pathogen that quietly rewrote the biological map of the Western Hemisphere.
So, picture this. It's the late summer of 1999.
Right.
You're in Queens, New York. It's hot, it's humid, and physicians at the local hospitals are suddenly facing this, totally baffling medical mystery.
It was completely unprecedented.
Exactly. Dozens of people are turning up in emergency rooms with profound brain inflammation, encephalitis, and initially, nobody could figure out why.
And, the answer to this localized human crisis didn't actually come from looking closer at the patients.
Right, which is wild.
Yeah, it came from looking up at the trees. Because at the exact same time, just over in the nearby Bronx, crows were mysteriously dropping out of the sky by the hundreds.
Just dead, falling onto the pavement.
Today, we are taking you into the startling, microscopic world of the West Nile virus. We've got a really robust stack of sources driving this deep dive today.
I do, yeah.
We're pulling from official public health data from the CDC and the World Health Organization, a really comprehensive clinical medical review from StatPearls, and a cutting-edge research paper on the genomic epidemiology of viruses.
And, that combination of clinical, historical, and evolutionary data allows us to trace a truly remarkable biological narrative.
It really does. Our mission today is to unpack the mechanics of how this virus achieves such a silent conquest. We want to understand how it actively hijacks the human immune system to, breach the brain.
Right, and why tracking its microscopic mutations through genomic sequencing is really our best defense moving forward.
So to understand the threat sitting in our own backyards, we have to start with how a virus native to the tropics managed to survive and, frankly, thrive in the concrete jungle of New York City.
Well, the historical trajectory is fascinating. West Nile virus is a flavirus, and it was first isolated way back in 1937.
In Uganda, right?
Yes, in the West Nile district of Uganda, hence the name. For decades, it was considered a regionally constrained pathogen. It caused periodic outbreaks across Africa, the Middle East, and parts of Europe and Asia.
But not here.
No, not here. The 1999 appearance in the Americas was entirely a shock. That initial outbreak in New York resulted in 62 cases of neuroinvasive disease and 7 deaths.
Which is terrifying. But, okay, knowing the climate differences between Uganda and a New York winter, I have to assume the virus didn't just drift over and tough it out.
Right, no.
It had to adapt or, I guess, find a host capable of surviving the freeze.
And that is precisely the mechanism of its survival. Genomic sequencing of the 1999 strain showed it was practically identical to a strain that was circulating in Israel a year prior.
Oh, wow.
Yeah, and when it arrived in New York, it quickly established itself in local Culex mosquitoes.
Culex mosquito.
Right. And species like the northern house, mosquito Culex pipiens, they are incredibly resilient. The adult females can enter this state of dormancy, which is called diapause.
Like hibernation.
Exactly like hibernation. They overwinter in subterranean environments. Think sewers, subway tunnels, basements.
So the virus literally hibernated in the blood of dormant mosquitoes beneath the city streets, just waiting for the spring thaw.
It did. And once that spring thaw hit, the numbers over the subsequent 2 decades became staggering.
Yeah, looking at the genomic epidemiology source, since 1999, there have been over 48,000 reporting cases and 2,300 deaths in the U.S. alone.
Which sounds high, but
the most alarming part of the CDC data is the gap between reported and actual infections. Because so many cases are asymptomatic, public health experts estimate the true number of human infections in the continental U.S. is closer to 7 million.
7 million. It's massive. And the sheer scale of those hidden infections points to a highly efficient ecological network.
Right.
We can't overlook the environmental toll either, which in many ways eclipses the human toll. The virus has devastated wildlife. It's caused widespread mortality in over 300 bird species.
The data on the American crow population is particularly striking. The sources documented a 45% population decline following the introduction of West Nile.
Almost half the population.
Yeah, but if the virus affects 300 species, what made the crow so uniquely vulnerable to that level of decimation?
It comes down to viral amplification. Corvids, so that's particularly crows and jays, they develop exceptionally high viral titers in their blood when they're infected.
So they're just packed with a virus.
Exactly. They are essentially highly efficient biological incubators for West Nile. Combine that high viral load with their communal roosting
Oh,
behaviors.
where thousands of birds gather together.
Right, in really close proximity. You create a hyperdense feeding ground for mosquitoes. The virus just rips through the flock with devastating speed.
So the virus didn't just arrive in the Americas, it tapped into a pre-existing transit infrastructure.
That's a great way to put it.
Migratory birds are the long-haul carriers, moving the virus up and down the continents, while the Culex mosquitoes serve as the local distributors.
The Culex mosquito is the critical linchpin, and they are uniquely adapted to urban and suburban environments.
Because they don't need pristine lakes to breed, right?
Not at all. They actually prefer to breed in nutrient-rich, stagnant water, the kind of runoff you find in street catch basins, clogged gutters, or, abandoned tires.
Just typical city stuff.
Exactly. And the transmission cycle is just a continuous loop. A mosquito bites an infected bird, incubates the virus for a week or two, and then passes it on to the next bird it feeds on.
Okay, but if the biological machinery of the virus is entirely optimized for that bird-mosquito loop, where do we fit in? It seems like human beings are effectively ecological collateral damage.
We are. In the language of epidemiology, humans and horses actually are classified as accidental dead-end hosts.
Dead-end hosts.
Right. The virus derives absolutely no evolutionary benefit from infecting us.
See, that term dead-end host, it feels like a misnomer to me, or at least counterintuitive. Well, it implies the virus hits a wall and immediately dies off, but obviously it can cause severe, sometimes fatal disease in humans. So what is biologically failing in the virus's life cycle when it enters a human body?
Ah, I see. Well, it's an evolutionary trap for the pathogen. In a crow, the virus multiplies so aggressively that a mosquito taking a microscopic sip of blood ingests enough viral particles to become infectious itself.
Okay.
But in humans, our immune response generally keeps the virus from flooding the bloodstream at those massive concentrations. We do experience viremia, which is virus in the blood, but the levels are transient and just orders of magnitude lower.
So the mosquito doesn't get enough.
Exactly. A mosquito biting an infected human simply will not ingest enough of the virus to pass it on to someone else.
So rather than a continuous transmission line, a human infection is like a viral echo chamber. The signal bounces around inside the individual, causing damage, but it doesn't possess the volume to escape to the next host.
That captures the dynamic perfectly. The chain is broken. Now, the CDC sources do note some extremely rare exceptions of human-to-human transmission, but these entirely bypass the mosquito vector.
Like what?
Scenarios like blood transfusions, solid organ transplants, or vertical transmission from a mother to a fetus during pregnancy.
Oh, wow. Cool.
But ecologically speaking, the human body is a dead end.
Let's trace what actually happens inside that human echo chamber then, because the clinical outcomes we read about are incredibly polarized.
They really are.
So a mosquito carrying the virus pierces your skin. What is the immediate biological cascade?
Well, the incubation period typically spans 2 to 14 days. When the mosquito feeds, it injects saliva containing the virus directly into the dermal layer of the skin.
Gross, but go on.
The virus immediately encounters our primary immune sentinels, the dermal dendritic cells and keratinocytes.
Those dendritic cells are essentially the security guards of the immune system, right? Their job is to capture foreign invaders and drag them to the lymph nodes to trigger an immune response.
Yes, and that is exactly the function West Nile exploits. It operates as a microscopic Trojan horse.
Oh, I hate that.
Yeah, instead of being destroyed by the dendritic cells, the virus infects them. It uses the very cells meant to sound the alarm as a protected transport vehicle to reach the regional lymph nodes.
That is so insidious.
It really is. From the lymph nodes, it multiplies and disseminates into the visceral organs. And this is where we see clinical outcomes diverge sharply following a well-documented 80-21 rule.
Right, let's break down that rule. The bulk of the population falls into the 80% category. These are the people who remain entirely asymptomatic.
Correct.
Their immune systems mount a successful defense, clearing the virus before it can establish a systemic foothold. And that accounts for those millions of unrecorded infections we talked about earlier.
Exactly. Most people never even know they were bitten by an infected mosquito. The next tier, though, is the 20% who develop what's called West Nile fever.
And what does that look like?
It presents as a sudden, acute systemic infection. Patients experience high fevers, severe myalgia, muscle aches, joint pain, headache, and gastrointestinal symptoms like vomiting.
Basically the worst flu you can imagine.
Yeah, and a subset of these patients will also develop a maculopapular rash on their torso.
The acute fever breaks after a few days, right? But the medical review in stat pearls indicates the resulting fatigue and malaise can persist for months.
Yes, it's a severe physiological tax. But importantly, the virus is still largely contained within the periphery of the body.
Okay, but then the clinical picture turns dire in that final 1% of cases. This is where it gets really scary.
It is. In this tiny fraction of infected individuals, the virus manages to breach the most exclusive biological fortress in the human body, the blood-brain barrier.
And the blood-brain barrier is notoriously difficult to penetrate. It's a tightly woven matrix of endothelial cells, specifically designed to keep blood-borne toxins and pathogens out of the central nervous system.
Exactly.
So how is a mosquito-borne virus managing to pick that lock?
The pathology is, well, it's complex. Current research, which is heavily detailed in the Stat Pearls review, points to a multi-pronged assault.
Oh.
The systemic inflammation caused by the virus triggers the release of cytokines, like tumor necrosis factor alpha. And these cytokines actively degrade the tight junctions of the blood-brain barrier, making it leaky.
So it softens the defenses.
Right. And simultaneously, the virus utilizes that Trojan horse mechanism again. It infects macrophages that carry it directly across the compromised barrier.
Unbelievable.
There's also evidence it can travel retrograde up the axons of peripheral nerves, essentially using the nervous system's own wiring to bypass the barrier entirely.
Wow. And once it accesses the central nervous system, it causes profound neuroinvasive disease. The literature categorizes this into three main manifestations, right? Meningitis, encephalitis, and acute flaccid myelitis.
Yes. So meningitis involves the inflammation of the meninges, which are the protective membranes surrounding the brain and spinal cord. Encephalitis is the direct viral infection and inflammation of the brain parenchyma itself. That leads to altered mental status, confusion, tremors, and in severe cases, coma.
And the third manifestation, acute flaccid myelitis. This is the one that truly highlights the virus's destructive capability.
It's devastating.
The clinical presentation is practically indistinguishable from polio. The CDC materials recount a case study of a man in Georgia who was just sleeping on his porch. He was wearing flip-flops, got bitten on the foot.
Just a normal evening.
Right. And within days, he woke up entirely unable to move his legs.
Yeah, acute flaccid myelitis occurs when the virus specifically targets and destroys the anterior horn cells in the spinal cord.
Which do what exactly?
Those are the vital motor neurons responsible for transmitting signals from the brain to the skeletal muscles. So when they are destroyed, the connection is completely severed. That results in sudden asymmetrical muscle weakness and paralysis.
If the biological mechanisms allowing the virus to breach the brain are that aggressive, it really raises the question of susceptibility. Why does the blood-brain barrier fail in that specific 1%? Is it purely random? Or are there definitive biological markers indicating who is going to face neuroinvasive disease?
It's not random. The data reveals a very clear demographic targeting. The single greatest risk factor for neuroinvasive disease is advanced age.
Age?
Yes. The risk of severe neurological complications increases exponentially for individuals over 65. When you look at patients over the age of 70, they are 6 times more likely to require hospitalization compared to younger adults.
6 times. That's a massive jump. That correlation with age points directly to immunosenescence, right?
Exactly.
The natural, gradual deterioration of the immune system as we get older. The initial innate immune response is just slower, giving the virus more time to replicate and degrade the blood-brain barrier.
That's right. And alongside age, the other primary risk factors involve significant underlying comorbidities.
Wait, what?
Well, patients actively battling cancer, those with poorly controlled diabetes, hypertension, or chronic kidney disease. Also, individuals on immunosuppressive medications, such as organ transplant recipients, they are at a profoundly elevated risk.
Because their immune infrastructure simply cannot mount the necessary defense to keep the virus out of the central nervous system.
Precisely.
Let's assume a patient in one of those high-risk categories arrives at the emergency room with a high fever, profound confusion, and tremors. Given that the symptoms overlap with bacterial meningitis and, frankly, a host of other neurological infections, how do physicians definitively isolate West Nile as the culprit?
The diagnostic standard relies on evaluating the cerebrospinal fluid. Physicians perform a lumbar puncture, a spinal tap, to extract a sample from the spinal canal.
Ouch.
Yeah, it's not pleasant. They analyze the fluid for elevated protein levels and pleocytosis, which is an abnormal increase in white blood cells. That indicates an active central nervous system infection.
But that just proves there's an infection, not that it's West Nile.
Right. The definitive confirmation comes from an ELISA test. They are specifically looking for West Nile virus IgM antibodies in the spinal fluid.
Now, because IgM antibodies are massive molecules, they do not easily cross an intact blood-brain barrier.
Exactly.
So if you find them floating in the cerebrospinal fluid, it proves the antibodies were manufactured locally inside the brain or spine, meaning the virus is actively replicating inside the central nervous system.
You nailed it. And once that diagnosis is confirmed, the medical reality is incredibly stark.
This was the most sobering detail in the StatPro's review for me.
I'm sure, because despite decades of research, there is no licensed human vaccine for West Nile virus.
Run.
None for humans. There's one for horses, but not for us. And there are no specific targeted antiviral treatments proven to alter the course of the infection.
We have mapped the entire genome of this virus. We know exactly how it breaches the cells. Yet clinical intervention in a severe case is limited entirely to supportive care.
That's the reality. Physicians are relegated to managing the collateral damage. They administer intravenous fluids, provide robust pain management, and utilize intensive nursing care to prevent secondary complications.
Like pressure ulcers or pneumonia in comatose patients?
Exactly. But the actual fight against the virus is left entirely to the patient's own immune system. The mortality rate for neuroinvasive disease hovers around 10%, climbing to roughly 20% for patients over 70.
And for the patients who do survive the acute infection, the medical review makes it brutally clear that clearing the virus does not mean a return to baseline. The neurological deficits are often permanent.
Very often,
Mhm.
between 30 and 40% of hospitalized patients sustain such profound neurological damage that they cannot be discharged to their homes.
40%.
Yeah, they require transition to long-term care facilities or intensive acute rehabilitation. Patients face grueling physical and occupational therapy regimens just to regain basic motor functions or manage lasting cognitive impairment.
And for a significant portion, the paralysis induced by acute flaccid myelitis will not reverse.
No, it won't.
So without a pharmaceutical silver bullet, no vaccine, no antivirals, our posture against West Nile has to be entirely defensive and anticipatory.
It has to be.
And this is where the final source in our stack, the paper on genomic epidemiology, offers a massive paradigm shift in how we approach vector-borne diseases.
It really is a game changer. Historically, public health responses to mosquito-borne viruses were largely reactionary. A cluster of human encephalitis cases would appear, and mosquito control units would rush to spray adulticides in that specific zip code.
Chasing the ghost after it already struck.
Right. Genomic epidemiology allows us to move from reacting to human casualties to predicting viral movements before humans are ever bitten.
The research paper details the use of open-source sequencing platforms like NextStrain. Researchers are continually collecting viral samples from trapped mosquitoes, dead birds, and obviously human patients.
And because the virus accumulates minute genetic mutations as it replicates, scientists can sequence the RNA and map those mutations.
Like an ancestral DNA test for a pathogen.
Yes, they utilize those genetic fingerprints to construct highly detailed phylogenetic trees. It allows epidemiologists to definitively link an outbreak in one county to a specific viral lineage that overwintered in a neighboring state.
That's incredible.
They can track the silent, localized spread of the virus through the bird and mosquito populations with incredible spatial and temporal resolution.
It transforms an invisible ecological process into a mapped grid. If the genomic data shows a highly virulent strain amplifying in the local crow population in early June, public health officials don't have to wait for a human to develop meningitis in August.
Exactly. They can deploy targeted larvicides to specific urban catch basins to cull the Culex mosquito population before the viral load crosses the threshold into human transmission.
It is the ultimate application of big data to public health. By understanding the evolutionary dynamics of the virus, how it mutates, how it shifts between hosts, and how it responds to subtle environmental changes, we can deploy our limited prevention resources with pinpoint accuracy.
We can't.
We've covered a tremendous amount of ground here today, moving from the macroecology of migratory birds down to the microscopic degradation of the blood-brain barrier. The overarching reality of the West Nile virus is that it is a permanent, entrenched resident of our ecosystem.
It's here to stay.
It is an evolutionary masterpiece that successfully capitalized on our urban infrastructure and the biology of local wildlife to establish an unbreakable transmission loop.
And, the fact that 80% of infections are asymptomatic is both its greatest disguise and the reason it will never be eradicated. It circulates quietly, amplifying in the background, making individual vigilance an absolute necessity, particularly for older adults and the immunocompromised.
The science is complex, but the personal application remains remarkably simple for you listening. You have to respect the biological reality of the environment around you.
Absolutely.
Deny the vector its breeding ground by eliminating stagnant water on your property. Empty those planters. Check your gutters. Utilize EPA-registered repellents like DET or picaridin when you are active during peak mosquito hours.
Wear long sleeves if you're out at dusk.
Exactly. Understanding the profound neurological threat this virus poses in that unlucky 1% should make those preventative habits non-negotiable.
And the story of West Nile also leaves us with a broader, more unsettling ecological question.
Well, yeah.
Well, the genomic data proves how rapidly a pathogen can mutate, adapt to a new hemisphere, and exploit an entirely new set of hosts.
Right.
As global climates shift, expanding the viable habitats for various mosquito species, and as human development pushes further into wildlife territories, we really must ask, what other obscure, localized pathogens are currently circulating quietly in the background ecology, requiring only a single genetic mutation or a single mosquito bite to bridge the gap and become the next permanent resident in our backyards?
Man, a question that ensures genomic sequencing and viral surveillance will remain at the absolute forefront of public health.
Definitely.
Stay informed, stay prepared. This has been Outbreak Brief.